All right, y'all. Hello. Welcome to week 4, where we are still talking about essentially mechanisms of change. So last week we focused a lot on the neurobiology. We will be continuing with some of that information this week. And then we'll expand a little bit into week 5 on different tools. So that'll be tools 3. But this week, we're talking about mechanisms, brain changes, and therapeutic windows. So we had 2 chapters out of our textbook to read this week. And let's start with the first one of human neuroimaging studies of serotonergic psychedelics. So this chapter is foundational for how we talk about psychedelic assisted therapy in a way that is scientifically grounded and clinically responsible. Rather than focusing on subjective reports alone, things like visions, insights, or mystical experiences, it asks a more difficult question. What is happening in the brain that makes those experiences therapeutically relevant? So, neuroimaging does not explain consciousness, but it allows us to see patterns of organization and disorganization that correlate with changes in perception, emotion, memory, and self experience. So, for therapists, this matters because therapy is fundamentally about changing patterns, patterns of meaning, affect regulation, relational expectations, and self narrative. So, throughout this lecture, what I want you to listen for is how psychedelics appear to temporarily relax entrenched neural hierarchies. So, this is creating a window where psychotherapy can intervene more effectively. So, this chapter is less about what drug does what and more about what conditions are created for change. So psychedelics are unique because their primary effect is not sedation, stimulation, or intoxication. It is altered conscious awareness. That includes changes in perception, emotional salience, self-boundaries, and meaning making. This is why traditional psychopharmacology frameworks struggle to categorize them. Their effects are highly context dependent and cannot be reduced to receptor binding alone. This chapter emphasizes the importance of human studies because only humans can report experiences like ego dissolution, autobiographical memory vividness, or shifts in existential meaning. Neuroimaging becomes the bridge between subjective experience and objective measurement. From a therapy perspective, this already signals something important. These substances affect the very systems psychotherapy targets, things like identity, affect, memory, and narrative. So again, just categorizing classic psychedelics, or also known as serotonergic psychedelics. The focus on so-called psycho or classic psychedelics is partly pragmatic and partly historical. Psilocybin, LSD, DMT, and mescaline were studied early, have relatively favorable safety profiles, and are ethically permissible in controlled research settings. Importantly, all of these compounds share 5-HT2A receptor agonism. As we know, agonist increases activity or encourages activity, antagonist decreases, which appears to be the primary molecular gateway into large-scale brain network changes. However, this chapter also highlights an important gap. Phenethylamines like mescaline and especially their modern synthetic derivatives, are widely used but poorly studied neurobiologically. This creates a mismatch between science, clinical interest, and real world use, which has implications for harm reduction and policy. Each imaging modality gives a different lens on the psychedelic state. EEG and MEG allows us to observe rapid changes in neural oscillations, so how synchronized or desynchronized brain activity becomes. PET scans and SPECT scans provide information about metabolism and receptor binding, answering questions like where energy consumption increases and how neurotransmitter systems interact. fMRIs allow us to examine networks, which is crucial because mental health disorders and therapeutic change are increasingly understood as network-level phenomena rather than localized deficits. A key theme of this chapter is that no single method is sufficient. Psychedelic efforts unfold across time, space, and systems, requiring multimodal approaches. Early EEG studies, despite major limitations, identified a robust finding that has stood the test of time. Psychedelics reduce alpha power and increase alpha peak frequency. Alpha rhythms are strongly associated with inhibitory control. They reflect the brain's ability to suppress irrelevant information and maintain stable perceptual and cognitive boundaries. When alpha power decreases, information that is normally filtered out, things like memories, emotions, imagery, can enter conscious awareness. This is not inherently therapeutic, but it creates the possibility for therapeutic engagement with material that is usually defended against. At this early stage, we see the beginnings of mechanistic explanation for why psychedelics feel subjectively, quote, opening. It's critical to be honest about the limitations of early psychedelic research. Many studies lacked blinding, relied on subjective interpretation of EEG traces, and were conducted under ethical standards that would be unacceptable today. Expectation effects were likely enormous, and statistical rigor was minimal by modern standards. Some reported effects, such as dramatic subjective changes at extremely low doses, have not been replicated. For us as clinicians and researchers, this history serves as a cautionary tale. Psychedelics evoke excitement, hope, but rigor, or excitement and hope, but rigor, humility, and ethics must remain central, especially when working with vulnerable populations. PET and SPECT studies added a new layer of understanding by showing how psychedelics alter regional metabolism and blood flow. Increased metabolic activity in frontal and limbic regions aligns with heightened emotional processing, meaning making, and self-referential thought. At the same time, decreased activity in the thalamus suggests a loosening of sensory and cognitive gating. Clinically, this supports the idea that psychedelics reduce top-down control while increasing bottom-up information flow, an important dynamic when working with trauma, depression, and rigid self-narratives. Although psychedelics are primarily serotonergic, PET studies show that they also influence dopamine systems, particularly in the striatum. Dopamine is associated with salience, motivation, and learning. Increased dopamine release may help explain why experiences under psychedelics feel deeply meaningful and emotionally charged. From a therapeutic standpoint, this may contribute to increased engagement, emotional investment, and openness to change, factors that are often difficult to access in chronic depression or trauma. Resting state fMRI studies revolutionized our understanding of psychedelic action by showing consistent effects on large-scale brain networks, particularly the default mode network. The default mode network is implicated in self-referential processing, rumination, and narrative identity. Under psychedelics, key default mode network hubs show reduced activity and connectivity. Importantly, these changes correlate with subjective reports of ego dissolution and altered self-experience. This provides a neural framework for understanding why patients, participants, clients may experience relief from rigid, self-critical thought patterns. The entropic brain hypothesis proposes that psychedelics increase the variability and flexibility of brain activity, allowing the system to explore a wider range of states. Entropy here does not mean chaos, it means reduced rigidity. Highly rigid systems are resistant to change. Moderately flexible systems are adaptive. In psychotherapy terms, increased entropy may allow clients to move out of entrenched patterns of thought, emotion, and behavior long enough for new learning to occur. Dynamic causal modeling studies suggest psychedelics disrupt thalamic gating within cortico-striatio-thalamocortical loops. The thalamus normally filters sensory and internal information before it reaches consciousness. When this filter is loosened, perception and emotion intensify. This explains both the therapeutic potential and the risks of psychedelic states. Without adequate preparation and support, increased information can become overwhelming rather than healing. Task-based studies show that psychedelics impair response inhibition and reduce top-down cognitive control. This has important clinical implications. During dosing sessions, cognitive behavioral or insight-oriented techniques that rely on executive functioning may be ineffective or counterproductive. Instead, therapeutic approaches that emphasize presence, emotional processing, and relational safety are better aligned with the neurobiological state. Psychedelics appear to recalibrate emotional processing rather than blunt it. Reduced amygdala reactivity to threat-related stimuli allows patients to approach difficult emotional material without being overwhelmed, while preserved responses ensures emotions remain accessible. This balance may underlie reported reductions in depression and anxiety following psychedelic-assisted therapy. Studies on autobiographical memory show increased vividness, emotional salience, and personal meaning under psychedelics. This is particularly relevant for trauma and depression, where autobiographical memory is often constricted or negatively biased. Psychedelics may facilitate memory reconsolidation, allowing old memories to be revisited in a new emotional context, especially when paired with therapeutic support. Psychedelics induce vivid imagery by activating sensory cortices even with eyes closed. Reduced retinotopic organization suggests that perception becomes less constrained by habitual sensory mappings. Music plays a critical role here, acting as an emotional and mnemonic scaffold that guides imagery and meaning making, hence its central place in clinical protocols. We'll talk a lot more about this next week, the music piece. Modern EEG and MEG studies confirm broadband decreases in oscillatory power, particularly in alpha bands within the default mode network hubs. These changes correlate with subjective experiences such as ego dissolution and visual imagery, reinforcing the link between neural distribution and altered consciousness. Importantly, these effects are blocked by 5-HT2A antagonists, confirming receptor-specific mechanisms. Taken together, these findings suggest psychedelics create a temporary therapeutic window characterized by increased neural flexibility, emotional accessibility, and reduced defensive filtering. The drug does not produce insight or healing on its own. Instead, it creates conditions under which psychotherapy can operate more effectively, particularly for clients stuck in rigid patterns. This underscores the importance of preparation, integration, and therapeutic presence. A major limitation of current research is context. Most imaging studies occur in clinical or laboratory settings that differ dramatically from therapeutic or ceremonial environments. Psychedelics are highly sensitive to set and setting, meaning neural findings may not fully generalize to real-world clinical practice. Future research integrating neuroimaging with psychotherapy outcomes may help predict who benefits most and how to personalize treatment. In regard to set and setting, we'll talk about this in coming weeks, but just so you can maybe it'll be helpful to understand it for this slide. Set is short for mindset, and the setting is the environment in which you essentially take the psychedelic. So in the case of my my postdoc studies, it was taken in a hospital room because it was a clinical trial, so we needed like access to doctors if, things maybe didn't go as expected. But we put like pictures up that were kind of expansive, that were focusing on like topography. We had mandalas. We also had colored scarves that covered, various clinical equipment. We also had a salt rock. We diffused essential oils if the participant was okay with that. And then, of course, they had the eye shades and the preset music selection. So all of those things are a part of the setting. And then the mindset was how we tried to influence their mindset through preparation, the four preparation sessions, and I'll get into the details of our study in future lectures. Um, but trying to help them or encourage them to be like open and yeah, open to the experience and open to whatever was going to come to them and to trust us as well. So that's set is short for mindset. Setting is the environment in which you take um, the substance. All right. And then just as we transition to the next reading, I want you to reflect on a couple of questions, but largely this overarching question. If psychedelics primarily work by increasing flexibility and reducing rigidity, what roles does the therapist play, or what role does the therapist play in shaping what that flexibility becomes? So the next chapter will push us further into how these mechanisms translate into therapeutic processes and clinical decision making. All right, so that takes us to our final reading of the week, the chapter on memory reconsolidation and psycholytic psychotherapy. All right. So this chapter is doing something very different from the neuroimaging chapter we just covered, where chapter 6 focused on what changes in the brain during the psychedelic state. This chapter asks a more clinically pointed question. How might these changes translate into durable therapeutic change? The author's core argument is that psychedelics exert their therapeutic efforts not primarily through insight, catharsis, or mystical experience alone, but through their impact on emotional memory systems, particularly through the process of memory reconsolidation. This is a crucial pivot for clinicians. Rather than thinking of psychedelic assisted therapy as accelerated insight therapy, this chapter positions it as deep affective learning that reorganizes neural networks associated with emotional memory. Throughout this chapter, I want you to track one central idea. Psychedelics open a window, but what changes during that window determines whether therapy heals, harms, or does nothing at all. One of the most important and most often misunderstood contributions of this chapter is the clear distinction between psycholytic and psychedelic psychotherapy. So I'll repeat a little bit from last week. Psycholytic therapy involves a low to moderate dose administered repeatedly over time. So involves low to moderate doses administered repeatedly over time, embedded within an ongoing psychodynamic or analytic process. The goal is not symptom relief per se, but personality restructuring, working through deeply rooted emotional patterns across many sessions. Psychedelic therapy, by contrast, uses 1 to 3 high dose sessions preceded and followed by non drug therapy. The goals are typically more circumscribed, reducing addiction, existential distress, or depressive symptoms. These approaches are not simply different intensities of the same thing. they likely involve different dominant mechanisms, which becomes critical when we think about reconsolidation versus peak experience models. Grisby follows Groff in emphasizing that LSD and psilocybin are best understood as non-specific amplifiers rather than targeted pharmacological interventions. Although these substances initiate their effects at serotonin receptors, especially the 5-HT2A, the cascade that follows is broad, complex, and highly dependent on context. This reframing is subtle but profound. If psychedelics are amplifiers, then they do not inherently push toward healing, insight, or growth. They amplify whatever psychological or emotional processes are already present. Clinically, this means that therapeutic outcomes depend less on the drug itself and more on what the client brings, what the therapist supports, and what the environment allows to unfold. Because psychedelics amplify rather than direct, set and setting become central determinants of outcome. Set includes personality structure, developmental history, expectations, and current psychological state. Setting includes the physical environment, relational dynamics, therapeutic frame, and the emotional tone established by the facilitators. From a reconsolidation perspective, this matters enormously. Emotional memories that become label during a psychedelic session can reconsolidate in a more adaptive or more pathological form, depending on the emotional context in which they are reactivated. This chapter implicitly reframes therapist responsibility. Facilitators are not passive sitters. They are co-regulators of the reconsolidation environment. Grisby introduces concepts from complexity theory to describe the psychedelic state. The brain is framed as a self-organizing system that normally operates in a relatively ordered regimen. Psychedelics push the system toward a critical state, poised between order and chaos. This is the same conceptual space described in Chapter 6 as increased entropy. Importantly, systems poised near criticality are maximally sensitive to being perturbed. Small inputs can produce large effects. Therapeutically, this means the psychedelic state is one of heightened plasticity, but also heightened vulnerability. This chapter is careful not to reify the ego or self as structures. Instead, both are conceptualized as processes emerging from coordinated network activity. The default mode network is not the ego, but it appears to support many ego-related functions like narrative continuity, self-referential thought, autobiographical memory, and identity maintenance. Psychedelics disrupt this coordination, which loosens the dominance of the narrative self and allows other modes of experience, particularly affective and somatic, to enter awareness. Ego dissolution is often discussed as a hallmark psychedelic experience, but this chapter emphasizes its variability and unpredictability. Neurobiologically, ego dissolution corresponds to decreased coherence within the default mode network and increased global connectivity across networks that are normally segregated. Clinically, ego dissolution is best understood as a byproduct of network destabilization, not a therapeutic mechanism in and of itself. Whether ego dissolution leads to healing, insight, panic, or confusion depends on what emotional material becomes accessible during this destabilized state. A key argument of this chapter is that psychedelics primarily affect emotional memory, not episodic memory. Clients may vividly re-experience fear, shame, grief, or longing without recalling specific autobiographical details. This distinction matters clinically. Therapy during psychedelic states should prioritize affective experience and regulation, not narrative reconstruction or interpretation. Just so many of you are aware, with psychedelic assisted therapy, or sorry, psilocybin assisted therapy in particular, while the I'll call it participant because they're primarily in clinical trials. That while they're under the influence of the of psilocybin, they're sorry, I'm shifting this now. It's bothering me. I don't know if it's even working. Okay, cool. Um, while they're under the influence of psilocybin, the facilitators, which is one of the what I was, we sit next to them or around them. We don't sit like right next to them. It'd probably be overwhelming, but we're largely quiet. And if the participant wanted to tell us what was going on, like what they were experiencing, we encourage them to just like go back in to their experience without talking to us because we wanted them to be in that affective experience and also practice some regulation as opposed to like telling us their narrative, making sense of it, interpreting it, trying to reconstruct it. That happens in integration. So just letting you know that, like with something like MDMA, for example, you talk while the person is under the influence of MDMA. With psilocybin, you largely don't. The only talking really is to like reassure that they're safe, reaffirm where they are. Like, so there were times that we would like let the person know, you are in Birmingham, Alabama, you are on UAB's campus, you are in our clinical unit, you are safe, when they may be getting like a little destabilized or disoriented. Okay, so Groff's concept of coex systems or systems of condensed experience is remarkably consistent with modern understandings of emotional memory networks. Coex systems consist of emotionally linked memories spanning different life periods, organized by affect rather than chronology. These systems are typically dissociated, exerting influence on behavior and perception without conscious awareness. Psychedelics increase the probability that these systems will emerge into awareness. Psychedelics reduce inhibitory control and increase emotional salience, allowing coex systems to surface. Importantly, the same coex system may reappear across multiple sessions, each time with deeper access to its core affect. This repetition is not redundancy. It reflects the iterative nature of reconsolidation-based change. And iterative just means like if it's, let's say stages 1, 2, 3, that you go 1, 2, 3, back to 1, 2, 3, back to one. So it's like circular. You can think of iterative as circular, but a little bit different is that in each kind of circle, there's like new information. So it's like circles that progress with evolution a little bit. This chapter draws on distinctions between declarative and implicit memory systems. Emotional memories are largely implicit and procedural. They shape behavior automatically and non-consciously. In conditions like PTSD, addiction, and depression, the core problem is not faulty cognition, but overactive emotional memory networks. Consolidation refers to the initial stabilization of a memory after learning. Reconsolidation occurs when a consolidated memory is reactivated, becomes label, and must be restabilized. During this label window, the memory is susceptible to modification. Psychedelics reliably induce these label states by reactivating emotionally charged memories. Extinction inhibits a memory but leaves the underlying network intact, which is why relapse is common. Reconsolidation can modify or dismantle the network itself, leading to more durable change. This distinction helps explain why psychedelic and MDMA-assisted therapies can produce large and lasting effects after relatively few sessions. Psychedelics facilitate reconsolidation by combining emotional memory reactivation with heightened neural plasticity. If emotional memories are experienced with acceptance, safety, and reduced avoidance, reconsolidation may weaken their affective charge. This is not catharsis, it is network reorganization. A critical warning embedded in this chapter is that reconsolidation is bidirectional. If emotional memories are reactivated in terror, coercion, or confusion, they may reconsolidate in a more pathological form. This reframes bad trips not as failure of mindset, but as failure of containment and facilitation. Psycholytic therapy allows for repeated reactivation and reconsolidation of multiple emotional memory systems over time. This is why it may be better suited for personality level change rather than discrete symptom reduction. Each session weakens a different coex system, gradually altering the emotional architecture of the self. Craving can be understood as an emotional memory network associated with wanting. Psychedelic assisted therapy appears to reduce craving intensity, potentially by reconsolidating these networks. This offers a compelling explanation for durable reductions in substance use after only 1 to 3 sessions. Insight, meaning making, and behavior change often follow emotional reconsolidation rather than precede it. Integration is a period during which reorganized emotional memories begin to reshape perception, behavior, and self concept. This explains why therapeutic change often unfolds over weeks or months. This chapter fundamentally reframes the therapist's role. Therapists are not guides toward insight, they are stewards of emotional memory reconsolidation. Ethical practice requires understanding the power and risk of inducing label emotional states. Together with Chapter 6, this chapter supports a coherent model. Psychedelics induce an entropic brain state that leads to emotional memory networks becoming accessible, where then reconsolidation becomes possible, and then therapy determines the outcome. The therapeutic window is not mystical, it is neurobiological, affective, and time limited. And that is your lecture for this week, y'all.